And I thought this topic, you are the appropriate person to talk about. And for all FNBs, DNBs in surgical oncology, this topic and this surgery is probably the bread and butter of their surgical career. Composite resections, various neck dissections, and mandibular dissections. And you can, all the FNBs, DNBs, or whosoever is attending, can type in the chat box if there are any questions. And I'm sure you will have. So over to Dr. Gauri. You can
Thank
start.
you, Dr. Devan. Thank you very much for that very kind introduction. I hope to meet you soon sometime. And welcome to all the students. My name is Gauri Pantavaidya. I'm a head and neck surgeon at the Tata Hospital. And as Dr. Devan very rightly pointed out, in your careers, this is probably going to be, if not 60 to 70% of what you will be operating. Quite a lot of complexities may not be possible to finish teaching everything in this talk, but I will give you an overview of all the surgical aspects for oral cavity cancers. Surgery is the mainstay of treatment for oral cancers. In very early stages, it may be treated as a single modality treatment, but in advanced stages, and most of our patients do present in advanced stages, surgery generally is combined with chemotherapy or radiation or a combination of two. But without doubt, surgery remains the mainstay of treatment. Now, to be able to choose a surgical patient correctly, and this is something that I want to bring to you all very early in your career, you must have a multidisciplinary team. We feel a multidisciplinary team is required for us to be able to know when to give radiation or know when to give chemotherapy. But I believe that even if you have to choose a surgical patient correctly, you should have a good multidisciplinary team. And this includes anesthesia, critical care, nursing, pathology, and rehabilitative services, along with radiation and chemotherapy. Now, coming to the general principles of surgery for oral cancers. Now, surgery is performed when three-dimensional adequate margins are possible. So, only choose a patient for surgery when you feel that you can get good three-dimensional adequate margins. If you feel that this is going to be an R plus resection or this patient you are not sure of margins, then this is not a good surgical candidate. There is no role in oral cavity cancers for us to remove some tumor and then treat it with chemoradiation, to debulk tumor or give positive margins before you plan surgery itself. Now, when we talk about margins, we need 1 centimeter margins in all three dimensions. And when I mean three dimensions, it's very easy to just see a tumor and get the margin, but you have to also palpate and get the deep margin. So you need a 1 centimeter three-dimensional margin on mucosa, bone, and soft tissue. Neck dissections are performed in a majority, and I will come through this. These are just the principles that I'm giving. For every oral cancer that we are resecting, before we take the patient on table, we must think of whether any appropriate reconstruction is required and plan accordingly for it, and post-operative surgical rehabilitation. There is no use of your surgery, your reconstruction, unless you give adequate post-operative surgical rehabilitation. So these are the general principles for any oral cancers. Now, I'm going to talk about two things: early cancers and locally advanced cancers. Now, early cancers, I will talk about surgery for the primary, a little bit of the neck and reconstruction. And in locally advanced cancers, I'll talk about extent of resection, extent of neck dissection, a little bit about reconstruction, and talk about these two terms that are often a little confusing, that is unresectable and borderline resectable oral cancers. So let's start with early cancers of the oral cavity. When we say early cancers, we generally mean node negative T1, T2 cancers. These patients overall have a good prognosis. Survivals are upward of 80% with adequate treatment. The issue with T1, T2, and 0 cancers are that they may predispose to second primary cancer. So you have to have good treatment modalities that you choose. Also, these patients need to be followed up for a longer time. Now, the aim of treatment in early oral cancers is adequate treatment with least morbidity, because most of these patients are going to live long. Now, what is the dictum that you have to understand when you're treating early cancers is we have to avoid small treatment for small cancers. We often find patients with a small patient has come to us with a small 1 centimeter ulcer on the tongue, and we go ahead and do a very small resection, and then this comes as a positive cancer, and in no time this patient gets a recurrence, which will then require excision of the tongue to a large extent. So you have to, even for the smallest tumor, follow the principle of oral cavity surgery, that is 1 centimeter margin, irrespective of what is the size of the tumor. So this is a dictum that we have to understand. These are patients who can be cured, who will live long, and the first chance should be the best chance, and you should avoid small treatment for small cancers. Now, the common surgeries that are performed are laser resections, wide local excisions, and sometimes for early cancers, we perform wide excisions with marginal mandibulectomies. Now, laser resections for early cancers are done for if you have a laser machine, are done for very, very small lesions. Generally, the bleeding that occurs with lasers is a little higher, so we don't even generally use it for T2. We generally use it only for T1. They should be easily accessible with no trismus. These laser resections can also be combined with with a neck dissection, so it does not. Laser is just a form of cutting instead of a cautery. So if you want to do a laser resection, it does not mean that you cannot do a neck dissection. Now, generally, what we use are CO2 lasers. The margins of resections remain the same. The principles do not change no matter if you use laser, you use cautery. You have a small 1 centimeter lesion, you still have to take a 1 centimeter margin. However, there is no proven advantage of lasers over electrocautery except for a possible reduced pain. So, if you can't do laser resection, it's absolutely fine. The resection remains the same. Now, here is a CO2 laser, and this is a small video of a patient who is undergoing laser resection for this is actually an erythroplakia. This is not a diagnosed tumor, but we are doing a small laser resection for this patient. So as you can see, margins remain the same that you will take irrespective of it's a erythroplakia or if it is a early oral cancer. Now, coming to the next surgery that's performed for early cancers, and that's called a wide excision. This is again a three-dimensional per oral excision of an early oral cancer. So you can see this is a slightly bigger tumor, but you have taken three-dimensional wide excision of this tumor. The third surgery that we do for early cancers is what we call a marginal mandibulectomy. Now, what is marginal mandibulectomy? As the name suggests, it's basically removing a margin of the mandible. Here is a segmental mandibulectomy where you remove the entire segment, whereas a marginal mandibulectomy, you remove only a part of either the upper margin, the lower margin. Sometimes you can do a lingual or a buccal plate. So, removal of a margin of the mandible for tumors which are close to the mandible but not involving it are called marginal mandibulectomy. Now, here is a classic example. Here is a small gingivobuccal sulcus tumor. It is not involving this mandible. Your CT scan has said it's negative for bone erosion. But if you try, you can see you will get 1 centimeter margins all around. The only area where you will not get a 1 centimeter margin is on the mandible. Now, excising the entire mandible for this kind of a margin is not acceptable. And so we do what is called a marginal mandibulectomy and excise only a part of this tumor. So this is what you will do. You will remove the alveolar complex, but you will leave at least a 1 centimeter height after you do this resection. So the indications are generally for buccal mucosa and floor of mouth cancers where 1 centimeter margin is not available on the mandible. The contraindications are bone involvement, a long-standing edentulous mandible. Now, there's a difference between long-standing and edentulous. Suppose someone has just pulled out 3 teeth and you find that there are no teeth, but this is a recent removal of teeth. You may be able to still do it. Now, the reason why we don't do it in an edentulous mandible, generally a marginal mandibulectomy, is because of constant resorption, this height becomes less. Now, for taking the forces of mastication, the remainder of the marginal mandible should be at least 1.5 centimeters. Now, if you have an edentulous mandible, then sometimes the entire height of the mandible is only 1.5 centimeters. So in long-standing edentulous mandibles, we do not do a marginal mandibulectomy. The third area where we don't do a marginal mandibulectomy is gross paramandibular spread. So if you have soft tissue that's seen at the side of the mandible, then it's difficult to cut through this mandible when you have a soft tissue sitting on it. And in those cases, you don't perform a marginal mandibulectomy. Now, those were the primary resections. Now, coming to the neck dissections in early oral cancers. Now, generally, the options that we have in early oral cancers are selective neck dissection, a sentinel node biopsy, elective neck irradiation, and observation of the neck. That is, don't do anything. Now, elective neck irradiation is generally not combined with surgery. So you can't say, I will just do a laser resection of the primary and then treat the neck with radiation. That's not a good philosophy to have. There is no proven advantage of that. For any reason, if you're treating the primary cancer with radiotherapy, then you may consider doing an elective neck irradiation. Now, observation of the neck, that is, if you have early oral cancer, that's T1, T2 oral cancer, can we observe the neck? This, as of today, is not really done, and I'll show you a little bit of evidence for that. Now, previously, for very early oral cancers, we used to observe the neck. It was called the wait and watch policy till we published this randomized trial where we showed that if you do a selective neck dissection, that is elective surgery, versus you can take a wait and watch policy, you will find that the survival is significantly more. So basically what happens is, if you have tumors, any sort of tumors with whatever grading, elective neck dissection is better than taking this patient up for wait and watch. So we feel if it's a small tumor, let's just resect it. Then we'll see if a node comes in the neck, then we'll operate it. But when that node comes back in the neck, it comes back in a very advanced stage. It may have perinodal spread in nearly 70% of these patients. And then the salvage of this patient is very poor. So you have a 12% survival advantage if you do the elective neck dissection right at the start of the surgery. Now, this has also been corroborated with another, this was our randomized trial, another study where they looked at, this was a randomized trial of 255 patients and a cohort study of 346 patients and a meta-analysis of 6 randomized trials, all in this particular study called the SEND study. This was published from the NHS, and a meta-analysis of 2 of our randomized control trials. Now, across all 4 of these analyses, that is the randomized trial, the cohort, and the 2 meta-analysis, the conclusions of this paper were also that elective neck dissection has a definite survival benefit over the wait and watch policy. And it doesn't matter how small your tumor is, even for a T1 tumor, size as well as less than 5 millimeters in thickness, elective neck dissection still showed a significant benefit. So for all patients as of today, even if you have a very small T1, T2 tumor, the recommended thing is to do a elective neck dissection. Now, which elective neck dissection will you perform when you have a node negative, that's an N0 patient? So as I told you, we are talking about early cancers. These are node negative patients. Now, a selective neck dissection involves the removal of only certain lymph node groups. As you are aware, 5 lymph node levels are what are at risk from oral cancers, level 1 to 5. Generally, what we do is a selective neck dissection where only certain lymph node groups are removed. These are not berry picking. You cannot just pick up lymph nodes from these levels. You have to remove all the fibrofatty tissue in this group of lymph nodes, and that is called as a selective neck dissection. And then you have to mention the levels that you are removing. It's either a 1 to 3 or a 1 to 4 neck dissection. Now, in this kind of neck dissection, all the 3 important non-lymphatic structures, that is the spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid, are preserved. So this is what we used to previously call a supraomohyoid neck dissection, or an SOHD. The terminology now has to be written as selective neck dissection, and you need to mention the levels that you have removed. Now, let me tell you a little bit about the other modality that we can use for a N0 neck, and that's called a sentinel node biopsy. Now, a sentinel node biopsy is a minimally invasive procedure where you use radio tracer, that is technetium 99 nanocolide. This is injected into the primary tumor, and this allows the surgeon to identify and excise targeted upper echelon nodes. If during surgery or postoperatively the sentinel node is positive, then you do a neck dissection. But if the sentinel node is negative, you can avoid a neck dissection. It is something like bridging a gap between diagnosis and treatment, and sentinel node biopsy is now being used more and more often. Now, the evidence for the use of sentinel node biopsy comes from these three studies. The SENT study was an EORTC based study. This was not a randomized trial, but it was a prospective multicentric EORTC group study. The Sentimerorel study was the first randomized trial, which was a French collaborative group randomized trial. And then came the third study, which was the Japanese study, which was again a phase 3 multicentric randomized trial from the Japanese collaborative group. What was basically shown is that a sentinel node biopsy guided neck dissection is non-inferior to a sentinel node to a selective neck dissection. But there are certain issues with sentinel node biopsy. In a small group of patient, if you don't get the sentinel node biopsy positive on frozen section and then you get a histopathology positive, you may require a second procedure where you have to take the patient back in and do a completion neck dissection. There is also issues with infrastructure and learning curve and costs associated for setting up your sentinel node biopsy program, which has nuclear medicine, surgery, pathology with serial step sectioning. And of course, it has been proven to be similar with regard to cancer outcomes, but whether doing a sentinel node biopsy decreases shoulder morbidity is not proven. However, what you really need for this is a surgeon, a nuclear medicine suite, a pathologist, a radiologist, lot of money and enthusiasm, and quality analysis and analysis of your results. Now here is a selective neck dissection that you have done. You can see the entire vein and artery and everything is this thing. The spinal accessory nerve is here. All the lymphatic tissue has been removed, and in a sentinel node biopsy, this is a small video that I'm showing you. This is how you do it. You preoperatively inject technetium dye, and then you look for confirmation of the location of the sentinel node using a probe, and you look at the radioactivity here. You then first excise the primary tumor to eliminate shine through effect. Now look at the small limited incision, skin incision that you take, and then you identify the location of the sentinel node in the neck, and then this sentinel node once it's identified is removed and sent for frozen section. If it comes positive, you will do a complete neck dissection. This is the small incision. However, you must understand this requires a whole lot of expertise. It is not something that we should start doing right at the beginning of our careers. It is better to learn and perform a good elective neck dissection, but you all should be aware of this procedure of sentinel node biopsy. Now, coming to the third aspect of early oral cancers, and that's reconstruction. Now, there are many ways that early oral cancers are treated after surgery. One is you let them heal by secondary intention. If it is a very small tumor, you can leave it raw. You can put split thickness skin grafts. You can use local flaps, or even for little bigger tumor defects, especially if you're doing things like a marginal mandibulectomy, you require microvascular tissue transfer. So please remember, even if you're dealing with early oral cancers, you have to give them a lot of thought. You have to look at how you will resect the primary with three-dimensional margins, that you will have to do a neck dissection also. And you also have to look at reconstruction in early oral cancers. Now, here are some of the pictures of local flaps that we have performed for early oral cancers. You can cover a good bit of defect, give the patient good tongue mobility. This is something even if you don't have facilities for microvascular reconstruction, you can learn local flaps. We do a lot of them at our center, and it is a good method of reconstruction for early oral cancers. Now, coming to one of the problems with early oral cancers, that is trismus. we found that trismus is a problem no matter what kind of reconstruction you do. Even for early cancers, you do primary closure, skin graft, local flap, or you do a free flap, you have a high prevalence of trismus for patients following multimodal therapy. It is not only adequate reconstruction. Please remember, just because you reconstructed a patient does not mean the patient will not have trismus. Patient requires aggressive rehabilitation in the form of jaw stretching exercises, especially if the patient is going to receive adjuvant radiotherapy. So, to summarize, surgery for early oral cancers: three-dimensional margins, 1 centimeter margins, no matter how small the tumor is. In most patients, you will perform an elective neck dissection. You may try to do selective neck sentinel node biopsy. The outcomes with regard to disease management is the same. Reconstruction has to be thought of even for smaller defects. And post-operative rehabilitation, as I said, is vital for good outcomes of your good surgery. Now, coming to the next section, which is locally advanced cancers. Now, it's a very common form of cancer in India. The early cancers are almost rare. Stage 3 or 4 is actually a very heterogeneous group. When we say stage 3, 4, it can include everything from T4B N3, which is the worst type of cancer, to a T2N1, which is the same. So, you cannot put all locally advanced cancers in the same bag. Generally, these patients will be treated with multimodal therapy. These patients, unlike the early oral cancers, will have high morbidity and toxicity. Unfortunately, in spite of all the surgery, radiation, chemotherapy, depending on which part of the spectrum you lie in, the survivals will be anywhere between 30 to 70%. Now, in advanced oral cavity cancers, I'll talk about extent of surgery. I will talk about defining what is unresectability and a little bit about this terminology called borderline resectable. Now, for all advanced oral cancers, the preoperative workup is very mandatory for us to be able to get that. The first thing I told you is you should be able to get 3 dimensional 1 centimeter margins. Now, to understand if you can get that margin or no, your preoperative workup has to be very good, or you'll start choosing the wrong patients for surgery, and your outcomes and the morbidity for these patients will be very poor. So, clinical examination and staging is very vital. A tumor board evaluation, wherever possible, will give you such wonderful insights that it really helps you choose your surgical patient well. You have to do appropriate imaging depending on where your primary cancer is. You do a CT scan or an MRI. A PET CT is not required in every patient, but in patients where you expect chances of distant metastasis, we generally do a PET CT. We do an NCCT thorax for lung metastasis, which is the commonest site in all patients of locally advanced cancers. Chest X-ray is something that is not a very good sensitive measure for looking at lung metastasis. We do preoperative dental evaluation for rehabilitation as well as if there are any issues, and a good anesthesia check. Now, what is the commonest surgery performed for advanced oral cancers? It's what we call composite resections. When we say composite, it means you're removing two, three different types of tissues. Unlike in early oral cancers, where you remove only mucosa or soft tissue, here you're removing two, three different types of tissue. So it generally involves excision of the mucosa, bone, and soft tissue. And in most cases, you do what is called a segmental resection of the bone and mucosa. So you can see the mandible has been cut here and the mandible has been cut here. And this is a composite margin, once again keeping the same principles of surgery in mind. Now, if you look at mandibular resections, there are multiple names and terminologies, and these may differ. You have what is called a posterior segmental mandibulectomy, where you cut it at the level of the last molar. Then you have a hemimandibulectomy, which, as the name suggests, you cut half of the mandible. You have an extended hemimandibulectomy, where you cross the midline, and you have what is called a middle third mandibulectomy, where you excise the middle one third of the mandible. Now, these are very subjective terminologies, and now we have a nice classification again coming from James Brown. James Brown is the person who has really done a lot of work on mandibular resections and the type of invasion of the mandible. And here are class 1 to class 4 defects of the mandible. We also have what is called a bialveolar resection, which we term as a bite composite resection, where you remove both the mandible and the maxilla when they are involved, and it looks like a bite like this. This is the upper alveolus and this is the lower alveolus. So these are called bite composite resections sometimes, but they are actually bialveolar resections. So all of these resections will be performed depending upon two things. One is what is your clinical extent that you have seen of the disease, which is important for you have to observe and palpate to find out how much of the mandible is being resected, and you have to look at your imaging findings. No resection, no composite resection is possible with either only imaging or only clinical examination. You have to look at your clinical examination and your imaging, combine the two, and then decide how much of the mandible you need to resect. Now, just like for the mandible, you have what is called a classification of the number of tongue resections that you can do. And this is an excellent paper by Jatin Shah's group. It has classified glossectomies depending upon how much of the tongue you have to remove both. Sorry, I've not put the 1A and 1B. These are the advanced tumors. That's why I have put only 3A, 3B, 4A, 4B, and 5. And this is two-dimensional description. So just the mucosa in the mediolateral way and in the superior inferior, depending on how much of the compartment you would resect, you have a classification of glossectomy. Now, this also is a combination of one clinical examination where you may require an examination under anesthesia, along with your imaging finding, which is going to give you both your mediolateral and your supero-inferior extent, and then you plan each of these glossectomies. Now, in oral cancer, most of these patients are node positive. Okay, so I'm going to talk about what are the principles of neck dissection in node positive oral cancers. Now, generally, what is performed is a modified neck dissection where you encompass level 1 to 5. But even in this, we have to spare as many non-lymphatic structures as possible, those which are not involved, the spinal accessory nerve, the IJV, and the sternocleidomastoid muscle. These structures have to be excised only if they are grossly involved by the nodal disease. Radical neck dissection is now almost non-existent, and it's only used for very, very large N3 nodes. Now, the problem that happens with this kind of a surgery is with modified neck dissection is you can see you have a drooping of this shoulder, and this is because of injury to the spinal accessory nerve. You may not have cut it, but even traction or ischemia can cause this problem, and then the patient gets what is called a shoulder syndrome. Now, this causation of sole shoulder syndrome is multifactorial. It can be because of injury to the spinal accessory nerve and the cervical plexus. Now, what can be done here is that sometimes you may try to avoid level 5 metastasis, and for this, you have to understand what are the patterns of spread of oral cancer. Now, in oral cancer, lymph nodal metastasis is concentrated. Generally, 91% we found were concentrated at level 1 to 3. Level 2B is one of the areas which has very low lymph node metastasis. Level 4 nodes are seen in 4.7%, and level 5 in oral cancers is seen in a very small group of patients. So majority, that is 96% of metastasis, if you see, are at levels 1 to 4 in patients of oral cancers. So people try to look at whether you really need to address level 5 or can you do just level 1 to 4 even in node positive patients. And this is a meta-analysis of 5 retrospective studies of oral squamous cancers which were node positive. 210 underwent a selective neck dissection. So it was a level 1 to 4. Level 5 was not done. Again, the reason we are doing this is to prevent that shoulder syndrome. Level 5 is where the spinal accessory lies, and dissection of level 5 definitely increases the chance of shoulder syndrome. So in 210 patients, selective neck dissection was done, and in 233 patients, the modified neck dissection was done. What did they find? In node positive, selective neck dissection along with adjuvant radiotherapy has good outcomes, and you can tailor the extent of neck dissection depending upon the levels involved. So in node positive patients, Selective neck dissection 1 to 4 may be adequate for most oral cancers with very low nodal burden. Now remember, if you have a node positive neck, you have multiple level 2, level 3 nodes, please do not do a selective neck dissection. If you have a single 1B node and you don't have majority of nodes in the lower neck, you may consider doing a selective neck dissection. Results are poor in the presence of extracapsular spread. So if you find extracapsular spread in your node positive patients, please do not do a selective neck dissection. It's better to do a modified neck dissection. Now, adjuvant radiotherapy should be part of the treatment algorithm if you're planning to do a selective neck dissection in a node positive patient. However, we have no level 1 evidence on the oncological safety of selective neck dissection or decreased shoulder function in node positive patients. So, if you have multiple nodes positive or levels 2 and below, as of today, the gold standard for node positive patients still is a modified neck dissection level 1 to 5. Now, coming to the last bit, which is reconstruction of locally advanced defects. You have to replace like with like, bone for bone, skin for skin. Now, in most of these patients with advanced defects, it is much better to do microvascular reconstruction. Free fibula osteocutaneous flap, anterolateral thigh flap, and the free radial forearm flap are the commonest used. It's not that we cannot use pedicle flaps, but you have to choose your patients very correctly for pedicle flaps. Here are some of our defects where you see a tongue entire total glossectomy defect has been reconstructed. You get a good bulk with an anterolateral thigh flap. Now coming to unresectable, and this is just a small bit for you all to understand these concepts, unresectable and borderline resectable. Now, when you say unresectable, what it actually means is gross skull base involvement, carotid artery involvement. But there are many other factors which can also make, and these are not defined anywhere in any guidelines, which can also make tumors unresectable, basically because you're trying to look at the prognosis of this patient and trying to see whether you get that 1 centimeter margin. Now, high infratemporal fossa involvement, involvement of the orbit by an oral cancer, erosion of the zygoma, extensive soft tissue involvement with multiple satellite nodules, pterygomaxillary fissure involvement, pterygopalatine fossa involvement may also make these tumors unresectable. So, to understand resectability, it is a combination of tumor extent, nodal status, age, and comorbidities of the patient. Whether this is per primum or this is a recurrent case where you may not have adjuvant therapy, the overall prognosis, morbidity of treatment, and quality of life of the patient, infrastructure and finances, and patient's choice. Now, here are some patients. This is a case of a patient who has a locally advanced cancer. This is another patient who has his disease going very high up here, right up to the zygoma. And there's always a question on whether this is unresectable, borderline resectable, resectable, or operable, and it is a gray area even today. We also have another terminology which is often used, and that's called borderline resectable cancers. Now, we have defined this in our paper. That is, if you have buccal mucosa primary with diffuse margins and edema or disease which is reaching up to the zygoma, you have extension of the tongue cancer that's going up to the hyoid. These patients are generally classified as T4B and they have advised non surgical managements. Basically, these tumors are biologically very aggressive subset. You have high margin positivity rates in T4 tumors and outcomes are poor. So, borderline resectability is an established concept in other cancers like pancreas, lung, esophagus, urinary bladder. It is prognostically poor, requires major surgery, and you have to look at the anatomic extent, biology, and morbidity of this surgery. And however, not everyone agrees on this definition. There are two options for borderline resectable, either neoadjuvant chemotherapy or upfront surgery. If we do upfront surgery in tongue cancers, it will involve total glossectomy with or without mandibular resection, with or without hyoid excision, limited supraglottic laryngectomy with bilateral neck dissection, and appropriate reconstruction. So, this is really an extensive surgery. You want to think about whether you want to do these surgeries and what is the prognosis. In gingivobuccal cancers, this will require a bialveolar resection in many patients, maxillectomy, skin excisions, and you have to do infratemporal fossa clearance along with neck dissections. Now, here is the definition of what is an infratemporal fossa. It's clearance. It's basically the removal of all contents of the infratemporal fossa, masseter temporalis, two heads of the lateral pterygoid, fat. Pterygoid plates are taken at the base of the skull with the entire medial pterygoid muscle, and the mandibular nerve is taken at the level of the foramen ovale. So it's an extensive resection, should definitely not be done unless you have good training and good infrastructure for this. Some of the patients here, this is a patient with extensive disease. We have done an infratemporal. You see how big the resection specimen looks, and this is the entire content of the infratemporal fossa that needs to be resected. So really major resections, we have to think about whether these resections after the morbidity that they cause are worth it or no. So finally, to summarize on advanced oral cancers, multidisciplinary decisions, again I'm saying for choosing the surgical candidate, it does not change no matter what type of cancer it is. You must get 1 centimeter three-dimensional margins. In these cancers, generally we do what is called compartment resections, either for tongue or for buccal cancers. Extended resections, remember, require microvascular reconstruction, extensive rehabilitation, and it's very important for us to find a balance between resection and the morbidity of this surgery. So it really requires good thinking before you take up a locally advanced oral cancer for surgery. Thank you very much. I hope you all have understood the overview. I'm very happy to take any questions for the next 5 or 10 minutes. Thank you.
Thank you very much, Dr. Gauri. Trainees, you may type your questions, comments in the chat box.
I think it is very, very important for all the DNBs and FNBs to understand that Dr. Gauri has highlighted this in initial slides, that decisions are more important than incisions of surgery.
Yes, very important.
Decisions are more important than incisions of surgery and precisions of radiation. You see, don't never ever do a debulking surgery and then say rest will be taken care of by radiation oncologist. That should not be the approach.
Yeah, so there's a
And
question. Yeah, go
yes,
ahead. Go ahead, Dr. Diwan. Please go ahead.
these same rules apply for minor salivary gland tumors also in oral cavity.
Yes, so minor salivary gland tumors will also, you will try to get a margin. It also depends on what type of a minor salivary gland tumor it is. If it's a low grade tumor, it does not mean that you can do any enucleations. You still need to get a good margin for them. But those margins may be a little smaller as compared to a high grade minor salivary tumor like a adenoid cystic cancer, where margins may be much higher. But yes, even for minor salivary gland tumors, you must look at margins.
So how much is adequate margin?
So it depends on the grade of the tumor. Now let's look at an adenoid cystic cancer. Now suppose you have an adenoid cystic cancer, sometimes you don't get margins at all. You may have a microscopic negative margin may be enough for an adenoid cystic cancer. But let's say you're talking of a pleomorphic adenoma of the palate, then for them a zero point 0.5 or a 1 centimeter margin will be enough. So it depends totally. In minor salivary gland tumors, the most important prognostic factor is the grade of the tumor. So it depends. So you have to look at your FNAC and your imaging well to try and understand what grade of tumor it is. And then accordingly, so if it's a low grade tumor, you will take around a 0.5 to 1 centimeter margin. In a high grade tumor, especially things like adenoid cystic cancers, sometimes you're okay having even a microscopic negative or a microscopic positive margin.
There is a question in chat box.
Yeah, I think there's a question on the mandibular resections because I think my
Some
voice
light
was.
on borderline resectability.
There's first a question on mandible resections, I thought. So I pulled this up so I can just explain that and then we can go for that. So
Okay.
if you look at mandibular, someone wanted to know mandibular resections. Let's go back to seeing this. So if you these are the different types of mandibular resections that are common terminologies. The common one is a posterior segmental mandibulectomy where you take it at the third molar, a hemimandibulectomy where you take it in the midline, an extended hemimandibulectomy where you cross the midline, and what we call a middle third mandibulectomy where the middle arch of the mandible is removed. But as I said, you need to look at this, and you can look at this James Brown's paper, which was published in the Lancet Oncology, January 2016. It gives a better understanding of the classification of mandibulectomies. So I see there is another question you said on borderline operable.
Borderline operability, resectability.
Okay, let me look at the question. I can't see it. Okay. Borderline resectable. Can you shed some light? I don't know what exactly is your question.
We
Uh,
actually covered.
Yeah, so I can say it again. So we
Hmm.
have, I would request you to look at our paper where we have defined what we call borderline resectable and we've published our data. Now, what happens in borderline resectable? Why did we come to this terminology of borderline resectable? You had resectable and you had unresectable. Now, in between these two, there were certain tumors where we were unsure of whether we will get that 1 centimeter margin, but they were not obviously unresectable. But we were not sure after clinical examination and imaging, we were not sure because patient had a lot of edema. When you cut through edema, you're not happy, you're unsure if you're leaving back microscopic margins. And I said earlier, for us, it's very, very important that if we are not sure of margins, we don't take this patient up for surgery. So we decided to bring an intermediate class of oral cancers, which is called borderline resectable. These are basically prognostically poor and patients in whom we are unsure we are going to get complete, clear microscopic margins. If you have gross margins which you are unsure of, that is, you have lot of tumor, those get classified into unresectable tumors. In borderline resectable tumors, we must try to look at some other form of therapy, and we use neoadjuvant chemotherapy in these patients. But before we use neoadjuvant chemotherapy, you must go through a multidisciplinary clinic to really ascertain that that is borderline resectable tumors. Otherwise, often even for operable cancers, we end up using neoadjuvant chemotherapy. So apply the definition of borderline resectable correctly. Do a good imaging analysis, be sure that this is actually a borderline tumor, and then you may consider using neoadjuvant chemotherapy.
I think you have answered the next question also, NACT in oral cancer. But
Yes.
the next question is very interesting. You have been saying 1 centimeter margin, and just now you said about skin involvements or edema of the skin. Here there is a question, amount of margin required at skin aspect for skin involvement.
So, there are two things when you resect the skin. One is when the skin is obviously involved, when you have like a fungating tumor, then the margin again is a 1 centimeter margin. Every tumor, wherever, so you will take a 1 centimeter margin on the skin when the skin is involved. Now, the question comes on when the skin is not involved but is close to the tumor. Now, that time you will take the skin. So, the skin is not obviously involved, but to get a three-dimensional margin, you need to resect the tumor. Then you need to remove only the skin which is abutting the tumor, and you don't need to take a 1 centimeter margin on that. But if your skin is involved, frankly, you again have to take a 1 centimeter margin around it.
Good. And then if there are satellite nodules over buccal mucosa, they appear to be limited to one area, maybe 3-4 centimeter area in skin, and there is brawny induration around it. You will call it as borderline resectable
So it
in your
depends on
practice?
how much of the area is involved. They come in so many types and this thing just to we have. So if you have it in the in the area around it, if it does not fit into our so for us, if the induration is crossing the zygoma, reaching up to the zygoma, then we call it borderline resectable. If it is just around the area, and it is in the lower part of the mandible, then we don't call it borderline resectable, and we will go ahead with upfront surgery for this patient. If the satellite nodule is somewhere far away from the primary tumor, then we actually consider this as a metastatic disease.
Any definition of metastatic disease in this regard? Satellite nodule, how far from the primary?
So there is no
2
such
centimeter.
definition.
Okay.
There is no such definition.
Any more questions? There
Yeah,
is
I
one
think that
more
is.
which has come up, synchronous primary approach.
So it depends on, I don't understand what the question is. It's only synchronous primary approach written. What is the question? Can you type that a little better, or do you want to unmute yourself? I don't understand. You've just written synchronous primary approach. Where are the two synchronous primaries? It can be in the mouth and in the larynx. It can be in the mouth and on one side, on the other side. Sorry, if you could just guide me on that. Till the time, we'll take the next question.
Next question is imaging of choice for oral cavity cancers.
Yeah. So if you look at imaging for oral cavity cancers, the most common imaging used is a CT scan. Uh, for tongue cancers, we generally use MRIs. If you But most patients will require a CT scan of the head neck. In locally advanced cancers, we also add head neck thorax. MRIs are generally done for patients who have tongue cancers because soft tissue delineation is much better with an MRI.
And
Same side or opposite side of oral cavity. So if it's on the same side, you have two primary, you have to see if the margin is either you resect them as two separate margins, or you can resect them together. Every tumor should have a margin of 1 centimeter. If it's opposite side, then you can resect both sides with a margin of 1 centimeter.
Madam, there is a clinical situation, locally advanced borderline resectability. You have given 3 cycles or 2 cycles of chemotherapy, neoadjuvant chemotherapy, and the tumor disappears. What is your approach? Give
So
radiation or do surgery?
no, we will do surgery. So, the best treatment for this patient will be with incorporation of surgery unless the patient is very, very keen on avoiding surgery. Even if we have complete response seen on the clinical radiological imaging, we will go ahead and do surgery for this patient and then give the patient adjuvant RT. We have to remember these are prognostically poor patients and require the multimodality treatment, including surgery. So as
A
of today,
person,
yeah, go ahead.
a person who has responded well to chemotherapy is likely to do well with radiation also.
Yes, but that is, we don't know without that is the same by adding by removing the surgery part of it, or by adding the surgery part of it. So as of today, for whatever evidence we have in neoadjuvant chemotherapy, it is always along with surgery that you have the good results. Unlike, let's say, in laryngeal or hypopharyngeal cancers, where yes, you can give chemotherapy, you can see what the response and then consider for chemoradiation, but that's not the same for oral cavity cancers. As of today, even if it's complete response, surgery has to be added into the treatment algorithm. On a case to case basis, if certain patients really want to avoid surgery, you may consider it, but I will not say that you can avoid surgery even after a good response to neoadjuvant chemotherapy.
And minimum number of nodes to be removed in supramoid neck dissection, elective neck dissection,
So
and
they say
MR.
18 nodes is what has been described that has to be removed. What I think you all should concentrate on is on the margins. What is the anatomic extent of each of these levels, and see that every bit of fibrofatty tissue has to be removed. But what is the number that's been recommended is 18.
For all type of neck dissections.
So modified neck dissection does not have a number.
Okay. And somebody wants you to share the first page of neck dissection.
First what? Can you share
Page
first
of
page?
page
Oh,
of neck dissection.
my slide, you are you saying?
Ah,
Okay,
yes, yes, slide.
okay, one sec, hold on. I don't know. I think you're talking about the selective neck dissection. Let me go back to it. I think this is the one that you're talking about. Can you see this?
We can see, but I think the candidate must be able to see.
Yeah. So this is what was my slide on selective neck dissection 1 to 3 or 1 to 4 and preservation of this. If you have any question related to this, please ask me.
Okay. I think there are no more questions.
Yeah.
Thank you. And I really enjoyed this lecture. I'm sure all the students must have clearly understood and enjoyed the topic.
Thank you, Dr. Diva.